as part of immunotherapy, we are looking at PD-L1 testing and biomarkers and enriching our patient population. And particularly for those with newly diagnosed disease, there are questions about that. So should all patients be tested? And how do we use the test results to determine frontline therapy? And I know, Fred, you've thought a lot about this. You've worked in this area for a long time. How would you summarize where we are?
Yeah, thank you, Everett. And of course, with the presentation of the results of Keynote 24 last year at the ESMO conference, Keynote 24 was the frontline study with pembrolizumab versus chemotherapy. And in that study, the patients were selected by PD-L1 expression using criteria of more or 50% or more for expression of PD-L1. And this study was showed superiority for pembrolizumab in frontline therapy in patients who are EGFR wild type, ALK or ROS wild type. So with that, there was a shift of paradigm for frontline therapy, and that made also, in my opinion, PD-L1 testing mandatory for all patients except those patients have an EGFR mutation or an ALK or ROS gene rearrangement. Now the problem is, in my opinion, it was clearly defined in the Pembro study, the assay with the clone 22C3 and a cutoff level of 50% or more, but there has been approved and used other assays. As you know, every company has their own assay. They have also in their package specific recommendations for the staining procedure and equipment, etc., etc. So, and even cutoff levels are different from study to study. So it is very clear that for frontline therapy, all patients should be tested unless they have an EGFR mutation, ALK or ROS rearrangement with that specific assay approved for pembrolizumab. Now, we have second-line studies where Pembro is approved with another cut point. We have complementary assays, which is not recommended for treatment, but which is not required for treatment, but recommended as a guidance for treatment effect. So the field is a little bit confused on this stage. So ISLC has taken upon the responsibility to work with the companies to compare the assays. That is what we call the Blueprint project. And the first phase of this project has already been completed and published. And they showed actually that 3 out of 4 assays was very similar, while one assay, SP142, which is used for atezolizumab by Genentech Roche, has a different profile in terms of PD-L1 expression. I think the Blueprint project is important because we hope that we one day eventually could harmonize the assays and avoid the confusion out in the communities and practices currently related to the PD-L1 assay. But with pembrolizumab, approved in first-line therapy based on this assay? The answer is everyone should be tested.
So
Naiyer.
So if you have a newly diagnosed patient and you don't have the right material or enough material for a PD-L1 test, do you send them for another biopsy for a PD-L1 test?
The scenario currently tells us that you should have a PD-L1 assay for putting the patient to pembrolizumab first line. I know there are certainly places where that doesn't happen, and I cannot, of course, recommend something which is not approved. So the short answer to your question is if you don't have sufficient material for PD-L1 testing and the patient is negative for EGFR mutation ALK-ROS, then I will recommend to seek a new biopsy.
And the reason for that is that there's a survival advantage for patients receiving pembrolizumab, or at least a progression-free, but also survival advantage for patients with PD-L1 staining over 50%.
Right.
And so you don't want to deprive those patients of that possibility.
Absolutely.
Is that correct?
Absolutely.